session.
Okay, sir. So we'll start. Yeah. Good evening, doctors. I'm Dr. Someshwar from Shield Healthcare, and I welcome you all on behalf of Shield. Thank you very much for joining today's webinar, and I kindly request all the participants to post their question in the comment section in the below, and we will have a short Q&A session at the end of the webinar. And so, good evening, Dr. HP Patnaik, sir. Thank you for
Namaskar.
accepting our invitation, and it's an honor to introduce you, sir.
Right. Thank you very much.
Sorry, sir, 1 minute. Chitrakala, could you able to share the screen? I can't able to share the screen.
Sir, just a minute.
Yeah, actually, sir doesn't need any introduction. Uh, he is a consultant gynecologist and endoscopic surgeon in Cuttack, Odisha, and he was a vice president for Foxy in 2009, and he was a president for Indian Menopause Society in 2015, and he was the vice president for IMS 2012, and he was the secretary general for IMS in 2010, and he was a founding secretary for IMS Odisha chapter, and he was a governing council member for ICOG from 2011 to 14, and he was a national corresponding editor for Foxy Journal from 2012 to 2015, and he was a chairperson for Geriatric Gynecology Committee, Foxy 2004 to 2008, and he was a president for Association of Obstetrician and Gynecologists of Odisha 2015 to 16, and sir is a ex special secretary for Health and Family Welfare Odisha, and sir is a ex director Health Services and director for Public Health Odisha. And thank you, sir. Thank you for accepting our invitation. And with this, over to you, sir, for the presentation.
Thank you very much, Dr. Someshwar, for those kind words. And can I share my screen?
Yes, sir, you can share the screen.
Okay. Right. Dr. Someshwar and Dr. Prachi, Mr. Venkatesh, Mr. Ganesh, thank you very much for giving me this opportunity from the platform of Shield Healthcare to talk to my fellow gynecologists and practitioners, medical practitioners. So today's presentation on menopause management and quality of life, or QOL, what we say. One great thing has happened this year. This virus, Corona, has taught us how to deal with situation in exigency and emergency. We have from real, we have converted to a virtual platform. And day in and day out, we are meeting people, we are talking, we are discussing academics on virtual platform, what we today call as webinar. Well, thank you again, and I come from the land of Lord Jagannath, and I bring him blessings to you all. And I hope that this virus is going down in Orissa, in many parts of the country, even though there is a second wave. But still, we are all hopeful that next time we will be in a real platform to discuss this issue. Well, today this is not new to me, and today, as I told you, that we will be discussing of menopause and quality of life. Because we all know that as age advances, the woman goes into a stage of menopause, and further, as she ages, there is issues of her quality of life. The life she leads, the situations she faces, the problems she experiences, the diseases she encounters are all affect her life. And more she asks question to a menopause consultant how to lead a quality life. It is our duty as menopause consultant to give them a healthy a life, healthy and a life with promises, with hope, and with real good, feel good factor. Well, we say that from periods with no wrinkles, as the woman was there in her young age, she converts into no periods with
Exactly.
wrinkles. Well, menopause is the end of menstruation. It is derived from a Greek word. No, it is a part of woman's natural aging process. There is nothing new to it. As the woman from puberty into reproductive period into a menopause, this is a stages of life. It's not a disease. And why you say it as menopause? Because there is a permanent cessation of menses, and that we say that it is landmark in woman's life, because the day she starts her menses, we called as menarche. It is the phase of puberty. Then she enters into younghood. Then she becomes adult. Then she becomes menopause. Then she becomes old. And this is the sequence. So menopause means main month. Pau means to stop. So it is simply that menopause means when menses stop, it is menopause. On the other hand, climacteric is climacter means a rung of ladder, means it's post menopause. So why does menopause occur? You know that cessation of menstruation occurs following loss of ovarian activity. When ovarian follicles are over exhausted from the ovary is depleted of the follicle, which secretes estrogen, the menses stop. And this is a phase of transition between reproductive and non-reproductive potential. So in India today, the natural age of menopause is 46 years. We know that. And but only 5% of these menopausal women really get treatment. The rest 95% are lost to oblivion, and they do not know that there is a treatment for that, and they accept the menopausal problem as a natural and normal thing. They do not know that there is a treatment available, and they have, even though that is available, they do not know where to get and whom to consult, and they have a very little expectation from the treatment which they will be getting, if at all they get. And average age of menopause in India is 46 years, and it is 2% lesser than Western countries. In Western countries, it varies somewhere between 48 to 50. And I will only tell that over the year, over the ages, age of menopause has already remained constant. And these menopausal women do have more than one symptom always. So the menopausal symptoms are a long list: vasomotor symptoms, psychological symptoms, physical symptoms, all these things. And hot flushes, night sweat, sweating, dissatisfied with personal life, feeling of anxiousness, nervousness, all these are psychological problems. Physical problem like gas, flatulence, aches, muscle and joint, feeling of tired and worn out. The prevalence of at least one symptom related to vasomotor symptom is around 21%. Physical problems really affects most of the women, around 91%. And psychological problem around half of the women. And sexual problem is really more, it is never 0%, because women in later year, they never discuss about their sexual problem. So the prevalence may be 0. Quality of life and bother analysis revealed that all those with menopausal symptoms also had their quality of life affected from mild to moderate, and to some extent in severe form it is affected. Let's discuss this. We know that uh, women has premenopause, perimenopause, menopause, and postmenopause. This is when menses stop for more than 12 years, 12 months, 1 year. When there is no menses for 1 year, we say that this woman has attained menopause. And this is derived in retrospect, because if she at age of 46 she does not have menses, she waits and waits. When she knows that there is no mens for last 1 year, then we think that at the age of 45 years she had her menses, last menses, and the age of menopause will be 45 years for this woman. So before that period we call it premenopause. So there is occurrence of real occurrence prior to menopause. The entire period is premenopause. But is menopause, you know that menopause and postmenopause, time after which the woman suffers is the postmenopause. So the problems of menopause really start in the premenopausal period. Next, I will like to say this. Premenopause, this is a phase in woman's life when cycles are usually regular, or occasionally they become irregular, but there is no noticeable changes in the body. But the hormonal changes may start to occur, and she is still in her reproductive phase of life. So this is simply 4-5 years before her actual menopause when she gets it. Perimenopause is rather a period. It is a transition phase of woman's life which begins several years before natural age of menopause, and the average length of this phase being about 5 years. The women do have irregular cycle in terms of length, in terms of frequency, and amount of flow. This is due to the fluctuation level of estrogen and other sex hormones during that time. They experience symptoms of menopause like hot flushes, night sweats, mood swings, etc. during perimenopausal period. Again, I come back to this picture. You can see the red line is menopause, and here is this period of menopause when she has no menses from this to this, and we stamp her that she has entered into menopause. The period previous to it, 40 to 45, 46, is premenopause, and in 46 beyond is postmenopause. But the period between this is a perimenopause. Somewhere starts around 3 years before that, around 2 more years. This is the transition phase, and she gradually gets and some period after menopause. Well, this is what I have already told you, that age at menopause has remained constant while life expectancy has increased. You know, earlier in the Roman era, the life expectancy was around 18 years. People were dying, and many women were not living up to age of menopause, and they have never had any problem of menopausal problem like hot flashes. They never had, because they were dying at the age of 40 or less at times. So over the years, you see the age of menopause has almost remained constant. And this is the graph for life expectancy, which after 1990 is going up and up, up and up and up and up. Today, the life expectancy in a female is around 80 years. In Japan, they live longer, more. In Western world, they live longer than Indian counterparts. So it is told that 30 years, a woman, if she survives for age of 80 years, for 30 years after 50, she remains, 1/3 of her life, she remains in postmenopausal estrogen depleted state. And she feels the problems of menopause. Today, earlier it was not there. So what are the hormonal changes in menopause? The circulating level of estrogen in the body falls. It almost comes to, it does not come to zero, because there is a peripheral conversion of estrogen from androgen and other things. And that is why in a woman's body, the conversion of estrogen comes from androgen. And that is why the ratio between estrogen and androgen is diminished, meaning that earlier the female hormone estrogen was more in the woman's body in comparison to androgen. the ovaries do secrete some amount of androgen and also in the peripheral organs. And when estrogen level falls, the ratio is altered, means the estrogen level fall in comparison to level of androgen. So sex hormone binding globulin secretion is also decreased because there is no estrogen. And there is a, I told that there is a peripheral aromatization of DHEA, dihydroandrosterone is converted to estrone. And that is why a some amount of estrogen is secreted in the woman's body from peripheral fat. So there is a reversal of estradiol in the reproductive period. The main dominant hormone estrogen is estradiol or E2. But in the menopausal period, it is converted. You have estrone and estriol to some extent. So the reversal of diol and estrone ratio. So estrone and estriol level rise up. There is no significant change in testosterone level. The testosterone level remaining same, the estrogen level will falls, the ratio of estrogen and androgen is becomes less. So when estrogen is diminished in woman's body, you see the manifestation of health risk over time. You see, at age of 45, 46, suddenly when she is depleted of all her ovaries and follicle, the level of estrogen falls because ovary does not secrete any estrogen further. And with this, the problem start. You see, regarding hot process, it starts somewhere before, immediately in the perimenopausal period, means from actual age of menopause, it may start little early before menopause and it continues. And one thing about hot process or hatomotor symptom is that it is self-limiting. It may continue for 3 to 5 years, and with treatment or without treatment, hot flushes go away automatically. And second problem, along with hot flushes, she has mood swings, she has sleep disturbances, she has acute cognitive changes. Next in order comes urogenital symptoms and the skin changes. So urogenital symptom is the second phase which is coming after hot flushes or after vasomotor symptom. It starts in the post-menopause, immediate post-menopause period when she has acute shortage of estrogen, and this in turn she has urgency, frequency, she has got vaginal dryness, dyspareunia, she has got loss of libido, and all these things cause urogenital syndrome or genitourinary syndrome or GSM, they say. Subsequently, there occurs cardiovascular disease. In fact, cardiovascular problem or the cholesterol changes does occur prior to actual cardiovascular diseases. But subsequently, it is evident, even though it is evident after 55 or so, these symptoms or the problems start earlier in form of coagulation problem, in form of altered lipid metabolism, and they become evident around age of 55 or so. Subsequently, usually the woman has bone formation occurs and the maximum bone density occurs around age of 35. After that, the bone becomes demineralized and it goes on. And slowly it goes on. And after menopause, when estrogen level suddenly falls, there is acute depression or what we call as osteopenia. But we are not able to see this feature. But somewhere around 60, we see osteopenic changes before that, and it is converted to osteoporosis and this osteoporosis progresses as up to 70-75. Last but not the least, there is a cognitive decline. In fact, immediately after menopausal period, she has initiation of the cognitive disorder in form of whatever you say, that dementia, she has got memory loss, she has got Alzheimer's disease, but it is more evident after some time or around 65 years or so, and it is progressive in nature. One thing, hot process and vasomotor symptoms are not progressive, they are self-limiting, But urogenital symptoms, skin changes, cardiovascular changes, osteoporosis, cognitive changes, all are progressive in nature. So there is a Cooperman index. I'm not going to the detail. This is a combination of self-report like vaginal dryness, hot flushes, paresthesia, insomnia, nervousness, melancholia, dizziness, fatigue, arthritis. All these are given a mark. And if these women are asked to say about what is her problem, so we mark for vaginal dress, give 1, hot flushes give 2, and these are the, if she has got all the 12 points, her Cooperman index is high. You know, this is the picture of estrogen receptor. How does estrogen act? The estrogen which is circulating in the body gets bound to the estrogen receptor found in the different parts of the body. And they show their action, they exhibit their action once they are attached to the estrogen receptor. If there is no estrogen receptor in that organ, the estrogen cannot get attached and the effect of estrogen will not be there. So number one, it is in the brain. So this will be in form of hot flushes. And this is brain. You can see number one. Number two, it is in breast. She has got breast changes. Initially, there will be inhomogeneous masses and subsequently changes, which is evident on mammography. Third will be in eye in form of macular degeneration. Fourth, in the genitourinary symptom, which I told as vaginal atrophy, stress incontinence, dyspareunia, dryness, loss of libido. Heart and blood vessel, she has got cardiovascular changes. Number 5, and she has got altered lipid metabolism, altered lipid profile. She has got thromboembolic phenomena, and this will lead to cardiovascular diseases and coronary artery disease. And liver is the active changes. I have already told that altered lipid profile. Ovaries is the main thing which I wanted to say, that ovaries are depleted for all ovaries. One more thing is that even though we say that ovaries are depleted of their follicles, but some ovaries really may remain, and even postmenopausal ovary do secrete some amount of estrogen, and there is a peripheral conversion of estrogen or estrogen from fat or adipose tissue. So skeleton, there is osteoporosis. Skin and hair, they become brittle, skin becomes wrinkled, there is loss of elasticity, loss of fibers. So all these are occurring because of the estrogen receptor present in the various organs of the body. So let's come to the symptom and the sign. So we say that we have already, Dr. Behra Mankleshwarya, our past president of Indian Menopause Society, has done an extensive study, and they have told about the menopausal changes. So they have divided into early, intermediate, and late changes. The early symptoms will be in the form of menstrual changes or cycle changes. Then early changes will be in form of night sweats and vasomotor symptom and vulvovaginal symptom. And irritability, insomnia are the middle, with skin changes or urogenital changes will be in the second group or intermediate changes. Osteoporosis, cardiovascular changes, neurological problem including Alzheimer's disease and other things are the late changes. So these are the things, early, intermediate and late changes. So other symptoms associated will be sleep disturbances, night sweats, cognitive concern, memory and loss of concentration, psychological symptom in form of depression, anxiety and mood changes. So let's come to the menstrual or bleeding changes. The changes which will occur initially, the first page when the estrogen level form, and there is along with this, there is a altered in estrogen and androgen level, which I have already told you. First of all, we'll discuss about the cycle length. The cycle length initially becomes longer, oligomenoric cycle. Then it becomes shorter or a polymenoric cycle. Then when there is infrequent ovulation, the cycle length may alter, sometimes long, sometimes short, and there will be associated with heavy to very heavy bleeding, which we call as abnormal uterine bleeding, or there may be lighter bleeding. The length of the cycle, duration of the bleeding, and cycle length, they are altered. And sometimes I have told that there is a skipped menstrual period. So let's come back to the vasomotor symptom, which I have already told, there is a recurrent, there is a transient episode of flushes, hot flushes accompanied by sensation of warmth, an intense heat in the upper part of the body, on the face, which radiates into the trunk and to the arms. As many as 75% of perimenopausal women in US have hot flushes, because our women are not that conscious. They do not complain about hot flushes. First, Western women are little more conscious than their Indian counterpart, so they complain about hot flushes more. So that is why it is 75%, because women in general do suffer. It varies from place to place. It is triggered by small increase in the core body temperature acting with reduced thermoneutral zone. So the treatment is based on symptom severity and a woman's risk and personal attitude about menopause and medication. So this is the picture: rise of core body temperature. It appears in the trunk, goes to the face and radiates to the arm. She feels as if she is hot, and then the heart rate begins to rise, and there is a skin blood flow is in the peak. So when blood flow is peak, she sweats a lot, and finally she has chill and shivering, and the hot process goes down. The vaginal symptoms, I have told you that symptoms are vaginal dryness or vulvovaginal irritation or itching and dyspareunia. This is because the vagina becomes depleted. The vaginal has three layers: basal layer, paravasal layer, and superficial layer. Because of the estrogen, the superficial layer is edematous, is thick in the reproductive period, full of glands. There is a lot of secretion. So the vagina becomes moist, is velvety, and it is warm. But when dryness occurs, meaning that when estrogen is depleted, the superficial layer reduces, and it is left with a layer of paravasal cells, isomere, and it becomes very thin. Once the vaginal epithelium becomes thin, say there will be scratching, and there will be rupture, there may be bleeding, and it is a coitus is difficult. She experiences dyspareunia, and dyspareunia leads to loss of libido, and this is a vicious circle. So from premenopausal, you can see that premenopausal vagina is well estronized, and she has a multi-layer, multi-superficial layer. Vaginal paravasal layer is well developed, as well as the basal layer. And when estrogen goes out, the superficial layer gradually diminishes in size, led to the few streaks, and there is less of glands, less of secretion, so the vagina becomes dry. It is because of the level of falling level of estrogen. So what about sexual health? Sexual health issues generally increase with aging. The woman experiences distressing sexual complaint, and it is peak during midlife. It is well known, and it is the lowest as the age advances, 60 years and beyond. Because in our this part of the country, women does not speak about their sexual life because of, they feel that it's a taboo. They feel that it is denied or devoured in to elderly women. But on the other hand, Western women are more open. They discuss about their problem regarding their decreased sex life to their doctors. But if an elderly lady comes to you, you ask her leading question, how satisfied she is during her sex life. She will open up. She may tell that yes, she has a problem. Decreased estrogen causes decreased vaginal lubrication, elasticity is lost, warmth is lost, it becomes dry. So decreased testosterone may contribute to a decline in sexual desire and sensation. So there is a loss of libido. So active sex life, you have, we say the concept is use it or lose it. So if you do not have sexual relationship, you get disinterested in sex. There is dyspareunia, there is dryness, and she is reference from sex, and this is a vicious circle, and it is continuing. So for that, you should encourage to have a local estrogen or vaginal estrogen cream. You can add lubricant, you can add moisturizer, and so that vaginal health is restored, vaginal epithelium is restored by local estrogen, and she can have an active sexual life. What about sleep disorder? Peri and postmenopausal women sleep less, or they have episodes of night sweats, they have episode of sleeplessness, and they have more frequent insomnia and more likely to use prescriptions of sleeping aids, sleeping pills, and there is a perceived decline in sleep quality, which may be attributed because of the general aging effect. Because she gets up for urination more, nocturnal urination, she sleeps less, and sleep disorder like sleep apnea or other illness like snoring and other things, chronic pain and depression. There is stress and negative mood, and this is all because of ovarian needs. So I have already told that because of hot flushes there is night sweats, and this triggers awakening. Suddenly she gets up, she has a lot of sweating, and she cannot feel. She goes out to have some fresh air because it is hot already, and she has a lot of sweats. And this is the first half of the night, but rapid eye movement or REM sleep in the second half suppresses the thermal regulation, and hot flushes are also suppressed. So decision whether and how to treat with behavioral drug therapy or both depend on the severe of the sleep disturbances. Whether you should treat and concept of the sleep problem and the severity, if it is more, she also can have daytime problem. Cognitive changes, the midlife women should be counseled that memory and concentration problem are probably not related to menopause. We all, as we all age, we all when we advance in our age, we have some problem of memory loss, and this is quite evident. You should accept it. The elderly woman or a menopausal woman has a memory loss to some extent, a loss of concentration, gets irritable, and she cannot focus on her work. And that is why there is a frequent mood changes, and there is more stress in other types circumstances. So she feels upset, loss of control, irritability, fatigue, flu moods like dysphoria, and this may cause a disturbances in her family life, and this is because of the hormone estrogen. So mood disorder, women with history of perimenopause syndrome, she has a lot of stress, sexual dysfunction, physical inability, hot flushes, and she has more depressive symptom in form of mood changes, in form of depression, in form of loneliness, in form of irritability and other things. The most predictive factor of depression in midlife and beyond is a prior history of clinical depression. She has a history of depression, she will suffer more. So relaxation and strain reduction technique will help more rather than antidepressant. Counseling and physiotherapy are better option than drugs. You know, there is changes in urogenital symptoms. This is the second part of the intermediary changes, or intermediate changes are described by Dr. Ankleshwarya. So this is common midlife women, but no, it has no, I will not say that there is some relation with estrogen loss, and over 50% of women above age of 50 has urinary incontinence. So urinary incontinence is a common factor in elderly women after 50 in form of symptom of overactive bladder. She go for frequent urination. She feels that she has incomplete voiding, and she goes to the toilet. The moment she feels that she is full, she runs to the toilet, and she has an urge, and she has a stress incontinence as well, and she has an urge incontinence, and she has overactive bladder. Mild incontinence in early perimenopause tends to decline in the first 5 years after menopause. So, and I have already told you that during this period of menopause, the woman also adds weight. So she becomes obese, and obese women are more suffering from overactive bladder. So weight loss for women helps. Kegels exercise is more important. There is a form of non-pharmacologic therapy in form of exercise. The main exercise is Kegels exercise, where she has to hold her urine by doing a pelvic exercise, and she should go for scheduled toileting. She should the bladder should be trained that every 2 hours she should urinate, so that she gets used to it, and she should take less water at night and more water in daytime, so there will be less nocturnal urination, so she will suffer less. and severe medication are approved for overactive bladder. I will talk to that. So after 50-55, I have already told that the maximum bone mass index is around the age of 30. After 30, the bone mineral density, the calcium and magnesium level starts falling. There is a loss of calcium and magnesium, which causes loss of mineral in the bone. And gradually after, and this estrogen has a protective effect on osteoblastic activity. So if there is more osteoblastic activity and less osteoclastic activity or bone breaking incidents, the woman has more bone mass index. So once the bone mass is reduced because the osteoblastic activity is less or the bone formation is less and bone destruction or bone resorption is more. So in such a situation, the woman will lose calcium from her bones or there occurs demineralization. And this results in osteopenia and subsequently which leads to osteoporosis. So this is the picture. So there will be initially there will be bone pain, there will be fracture risk, impaired calcium and vitamin absorption, and there will be it lead to osteoclastic activity and less osteoblastic activity, and it will go on. So when the bone becomes compromised, the bone becomes porous. This is called osteoporosis. And this is a serious health threat because women in the postmenopausal period are severely osteoporotic, particularly in the neck of femur. And she has in the spine. So there is a fractured spine or osteoporotic spine or fractured neck of the femur. And this fracture, osteoporosis of the hip, this results in pathological fracture in the spine as well as hip as well as in the femur, and this is described in form of BMD, bone mineral density result. It is called as T score. In a normal, the T score remains equal to -1, and low bone mass or osteopenia, it becomes -1 to -2.5, and if it is less than 2.5, -2.5, it is called osteoporosis. So risk factor of osteoporosis as you measure from Frax index, what do you call, and is all these things advanced age, paternal history of fragility, fracture, female sex, current tobacco smoking, weight, obesity, long-term use of glucocorticoids, height, rheumatoid arthritis, low femoral neck BMD, prior pathology. All these are the risk factor for osteoporosis in an elderly woman. So we come to cardiovascular changes. This increases coronary heart disease and stroke. So in coronary heart disease, it is the CVD is the second leading cause of death among US women around age of 45 to 65. And after age of 65, it is the leading cause of death in women in Western world. So coronary heart disease, death rate in younger women, that means in 35 to 54, are increasing for the first time in 4 decades. Why? Because of obesity, because of diabetes, because of hypertension. When there was no obesity, no diabetes, no hypertension, only postmenopausal women, it was occurring little later. But now it has occurred. So what about the cardiovascular health? We know that there is an altered lipid metabolism, meaning that the total cholesterol, the HDL, so total cholesterol level should remain by 2 milligram per deciliter. I'm not going to that. So HDL at least should be 50 milligram, and the ratio I have already told you. Blood pressure should remain less than 120/80. Fasting blood sugar should remain below 100 or less, and BMI should be around 25 kg per square meter of body. It can, and she should quit smoking, quit alcohol, and there will be more physical activity in form of walking, in form of light exercise, in form of vigorous exercise. So she should walk, or she should work actually minimum 5 days a week, at least 20 to 30 minutes. This will be helping her to bring her bone mass, to bring her muscle mass to normal, and she should have a rich, healthy diet. I'll come to that later. Well, menopause is not associated with cancer. But we know that when menopause occurs, woman becomes elderly. With age, cancer risk increases. But it is not exactly related to menopause. But cancer becomes the second leading cause of death in women. And the cancer number one is breast cancer, colorectal cancer, endometrial cancer, and ovarian cancer. So all these women in the postmenopausal period should have a screening test or checkup for these cancer at least. CA breast, CA cervix, CA endometrium, and breast cancer and colorectal cancer. So, breast cancer, you should have mammography at a regular interval every 2 years. Colorectal cancer, sigmoidoscopy, endometrial cancer, endometrial evaluation by histoscopic evaluation or endometrial sampling. Ovarian cancer, there is no satisfactory screening test because they do not have any symptoms. They are absolutely asymptomatic and there may be bloating or bleeding. So there should be a regular interval. They should be evaluated. Ultrasound may reveal. Cervical cancer is most important because pap test should be done every 3 years, or if it is associated with HPV testing, then at least every 5 years. And this is a single cancer which is 100% preventable if we are doing a pap test. So with all these problems, starting from early symptoms of vasomotor symptoms and mood changes, which I have already discussed. Second problem of skin changes and urogenital changes, which we call as intermediary problem, and late sequelae in form of cardiovascular changes, in form of osteoporosis, and in form of neurological changes, Alzheimer's and dementia. We have to give these women treatment, and we should discuss about the management. The management is not exactly the drugs first. The first and foremost is give them a healthy diet or lifestyle management. So lifestyle management has 3 steps: eat right food, do good exercise, and then comes medication. And all these menopausal women should be trained, treated, and counseled properly, so that they must know what should they eat and how much they should exercise and what drugs to take. So the recommended sugar, salt, oil, fruit. We all tell that the oil restriction should be there, and they say they must have enough fruit in their diet, more vegetables, and they must have more salads and more fruits, and they must drink 8 glasses of water every day, and they must have flaxseed, cinnamon, fenugreek, sonap, and salads and yogurt or curd in their diet. This will enrich their diet with more vitamins, trace elements, and other vitamins, so that they will be immune boosters. They will be building their body. Regarding, we say that they should avoid tea and coffee. The less is the better. So avoid more than 200 milligram of caffeine per day. We say that there should be a restriction. Limit intake of tea at least 3 cups a day. You know that. And they must instead they have more dairy products in form of milk and yogurt. And this and it should support with more vitamin C rich fruit and vegetables, lemon, oranges, and other things, and more of yellow vegetables for vitamin A and D. So the recommended dietary allowance for calcium and vitamin D for adult women is the calcium should be around 800 to 1200 milligram per day, and she should maximum up to 0.5 gram per day. Vitamin D around 1500 to 2000 international unit, and I will not go to the upper limit. And the women should be encouraged to have a sun bath, go on the move in the morning sun, so that she gets lot of vitamin D. So exercise, there is a lot of things. The Indian Menopause Society recommends exercise prescription to all elderly women, all menopausal women. So it should include aerobics, muscle strengthening, breathing exercise, and balancing exercise. So what I want to say, that moderate to brief, if physical activity in form of morning walk, at least 30 minutes and at least 5 days a week, to help a lot. Along with bone mass index, he has a muscle mass index occurs also decreases, which we call as sarcopenia. And this should be encouraged with the exercise. And if she has a good legs, she will be able to walk properly because of the good muscles, triceps. So that is why she should have more exercise for this. Well, the cancer risk and obesity, they go somewhat time to side by side. You see, this is a 7 type of cancer in women. The number 1 will be breast and endometrium, and next will be bowel, next will be kidney, next will be esophagus, pancreas, and a small amount of gallbladder. So the main cancer risk is breast and endometrium. So, of course, cervix is there. So that obesity can increase the risk of all these 7 type of cancer by 41%. So how to avoid it? Healthy weight. She should remain thin and should not go for overweight or obese. This will also help her. So I have discussed about the lifestyle modification in menopause before actual menopause medicine or treatment is given. So the woman should be counseled properly. She should be physically fit, for which she should have good food, diet, exercise. She should be socially adaptive or accommodative. So she should go out more often, have recreation, relaxation, reading, writing, going for picnics, seminars, all these things which she likes. And she should be counseled. If she remains alone, there will be loneliness, there will be depression. So she should enjoy in a club somewhere so that her time passes and she should not remain lonely alone. And finally, diet. And finally, there is a need for a psychological rejuvenation. And antidepressant are not the answer. And finally, to the treatment option. So the treatment option will be in form of hormonal. Mainly, the concept of treatment is that because estrogen depletion is the cause of menopause or menopausal problem, estrogen supplementation should be the answer. And so let us first talk about the hormones, what we call as menopausal hormone therapy or MHT. So the estrogens, there was a estrogen were given in form of hormone replacement therapy in earlier ages, in 90s. And the estrogen component which was given, it was conjugated equine estrogen, 0.625 milligram, along with progesterone, medroxyprogesterone acetate, 10 milligram. And the progesterone was supplemented in the later part of the cycle, last 10 days. Why? If the woman has an intact uterus, unopposed estrogen may cause endometrial hyperplasia. Endometrial hyperplasia will lead to endometrial cancer. To prevent the unopposed action of estrogen, progesterone was supplemented in the later part of the cycle. So this prevented endometrial cancer. And for that, you know that there is a huge trial took place, which we call as WHI trial or Women Health Initiative trial. So that I am not going to detail. And HRT in those days where primarily the estrogen was conjugated equine estrogen. Subsequently, we have now left conjugated equine estrogen. We are using natural, and this is 17 beta estradiol, hemihydrate, or estriol or estradiol valerate. And when the woman has an intact uterus, we supplement the progesterone along with estrogen. And the progesterone are natural micronized progesterone number 1, dihydrogesterone number 2, drospirenone and other things which I will come to later. The second group are the women as the age. They have osteopenia and osteoporosis. So we promote anti-osteoporotic treatment. The anti-osteoporotic treatment means first supplement with calcium and vitamin D. Second is that selective estrogen receptor modulator, or what we call as SERMs. The age-old drug is raloxifene, which is very effective in prevention and treatment of osteoporosis. At least it prevents. And then comes the isoflavone, soy isoflavone. It comes from the concept. Isoflavone has come from the concept that soy has a lot of isoflavone in them, and they suffer from menopausal symptoms less because of Japanese concept. Japanese people take a lot of soya. So once they soya, these Japanese women live longer, and because the soya contains a lot of isoflavone, this isoflavone gives them less effect on menopausal problem, and that is why isoflavones are recommended. And today, many women as a anti-resorptive agents, they take isoflavones. Then comes the actual bisphosphonate in form of alendronate and bisandronates, and non-HMT option. I will come to that because alternative therapy has come. Why alternative therapy has come? I will come to that later. So let's finish estrogen first. So estrogen doses in Indian Menopause Society has recommended today, because of problem of other diseases or cancer risk, we are advocating lowest possible dose of estrogen on the shortest possible period. As long as the woman needs it, she should be given. Earlier, the standard conjugate equivalent estrogen was 6.625 milligram, and gradually, and she was going to take 1.25 grams, which is called a higher dose. Now we have come to the lower form, and it's 0.3 to 0.45, and even ultra low 1.5. 17 beta estradiol, the lower actual standard is 2 milligram orally, and there is a low and ultra low as well as high. Estradiol valerate is given orally, standard is 2 milligram again, and transdermal 17 beta estradiol cream or patch, which can be given on the skin patch or vaginal gel, and this should be 50 microgram, and this can be ultra low and higher as well. But the problem of HRT is that I have already told that if estrogen is given alone, it causes endometrial hyperplasia, and endometrial hyperplasia will lead to endometrial cancer. So there is an increased risk of endometrial cancer in hormone taking women. So that is what the WHO trial reported. But all women do not suffer from that. Only there is an increase of endometrial cancer in those women who are taking hormones. Second is there is an increased risk of breast cancer where they are taking combined estrogen and progesterone. The progesterone component is the culprit here. There is increased risk of venous thromboembolism. It is because of estrogen component again. There is weight gain because of progesterone. Lipid metabolism is altered, and there is increased incidence of gallstones, and there is the bleeding problem. So these are the problems of hormone replacement therapy, and that is why people become afraid to take hormone. People become afraid to take hormone, which in the post-WHI report, and because the media hype, they told that estrogen causes cancer, people are afraid to take hormone after that. So I have already told that soya or phytoestrogen or estrogen. So this is a group, or a phytoestrogen are called plant estrogen, and they have isoflavone, they have legumes and product which are potent, effective estrogen mimicking molecules. So that is why they have some amount of symptom relief in form of isoflavone. That is what we call their weaker estrogen. But the problem is that we did not have enough data or trials on these isoflavones. That is why people have taken, they have a mixed reaction on the effectiveness of isoflavones or soya or black cohosh or other things. So there is a meta-analysis on black cohosh, and it is found entirely that even though we give these as an alternate to hormone replacement therapy in women who are apprehensive to take hormones, or who have a family history of cancer, or who are totally against taking hormones because they fear, they are prescribed isoflavones, and they have got some relief or no relief at all. So there is a lot of isoflavones in prevention of menopausal bone loss and menstrual symptom. And the conclusion is this: in this population, daily administration of tablet containing 200 milligram of soy isoflavone for 2 years did not prevent bone loss or menstrual symptom. In fact, the drugs for osteoporosis should be on the form of syrups, on the form of bisphosphonate, alendronate, and thandronate rather than isopropyl. So now that there is a think tank which goes on that if estrogen causes cancer and we need an alternate solution, we need an alternate solution to estrogen. And this ideal estrogen or ideal hormone, we are in search. A molecule, such a molecule, which should be breast safe and bleed free. It will not have any action or stimulating action on breast, so that there will be no breast inhomogeneity in form of breast nodules or in form of breast masses, or there should not be excess endometrial stimulation to cause endometrial cancer. So this should regulate endogenous estrogen to non-reproductive organ as well as reproductive organ. What will the effect of reproductive organ? There should be less stimulation on reproductive organ like breast and endometrium. There should be more stimulus on non-reproductive organ like heart, like bones, like skin, so that there will be added or extensive action of estrogen in these organs, so that there will be well-built bone and well-built skin, and there should be good amount of urinary problems should be reduced. So we want a good hormone or a drug which should be risk of cancer should not be there, risk of venous thromboembolism, stroke, and we should not be there. So that is what I was telling, that estrogen affinity to estrogen receptor, there is a up-regulation on non-reproductive organ and down-regulation on reproductive organ. So medical herbs, ingredients showing promising result, they have been tried by cinnamic acid, by methyl ester, and there is a lot of research is going on in this field, and the literature is full in this. I will like to say that today there are many new drugs are come up in the market, and the new molecules are come up, and which with the hope that this will not cause endometrial hyperplasia, they will not cause breast stimulation or breast problems, and they should have a positive effect on the bone, they will have a positive effect on lipid metabolism, they will have a positive effect on urinary symptoms. And this is this product which we are today calling as Estrogen 100. Many centers and many people have tried this drug, and it is claimed that it is a non-estrogenic hormone regulator. It has no affinity to ER alpha or BR beta, and this, because of this, it does not causes stimulation in the breast or endometrium. So the evidences has shown that there are 3 randomized placebo-controlled trial, and one conducted in USA, 2 conducted in Korea, and there is a lot of literature available this, and the both objective and subjective parameters are validated extensively, and the evidence that vaginal dryness, hot flushes, mood swings, and bone pain, this is relieved with the symptoms within 7 to 14 days. And with estrogen 100 group, there is a significant reduction in Cooperman index from 10 out of 12. So the safety and efficacy of this drug has been tried in form of Cooperman index, in form of hot flushes. It was found that in comparison to placebo, the Cooperman index is low and the hot flushes is reduced. And the effectiveness on perimenopausal women for 1 year, it has been found that the femoral bone density is increased, and the woman, if she takes this, she has more bone mass index. So the parameter wise, we had increase bone mineral density, increase serum growth hormone, decrease osteocalcinin, which causes more osteoclastic activity, decrease triglyceride level, and decrease ALT. And in NIH study, this was the found, and this is more in estrogen 100 as claimed by the Korean study. So the pivotal phase 2 trial, it was been found that the woman which was given estrogen 100 twice a day, the bone mass density and serum bone markers and BMI has increased proportionately. So perimenopausal women may have a benefit from this drug estrogen 100, a supplement essentially for climacteric symptoms, femoral bone neck BMD, serum triglyceride, human growth hormone without weight gain and any serious side effects. So that's the picture that they get. So in conclusion, there is no adverse event were reported with this new molecule which they called as estrogen 100. So estrogen can be given for a period at least 12 weeks, statistically significant improved quality of life. And it is also an ideal drug for surgery induced menopause. That means surgical menopause or hysterectomy or oophorectomy. Even in the earlier age, the woman has more and severe menopausal symptom in comparison to natural menopause. So this here estrogen 100 is very effective. So the effect of herbal extract in pre, peri and post-menopausal women, it was found in comparison in a randomized double-blind control study. It is not active on estrogenic compound and the mean serum FSH level remains unchanged in the prescription of estrogen 100. So, second thing, any drug which has a effect or action has a reaction or a side effect. So we are more worried about the toxicity of the drug. And it was found that estrogen 100, even with a 2 gram per kg body weight, it has got no toxicity as claimed by the study. This has been accredited by US, Canada, Europe, and Asia, and a different government has approved this drug. So, ladies and gentlemen, I discussed about the menopause and menopausal problem. The problem the menopausal women face today, because these women they live longer, they suffer in the post-menopause estrogen depleted state for more than 30 years as they live up to 80. So the symptoms are more acute, more severe. They are lonely. They have lost their partner. They are not counseled anymore in their family. So they lead a life of seclusion. The urogenital problem is increasing. The urgency, frequency is increasing. They have irritability. They have vasomotor symptoms. All these lead to their quality of life. And these women really have a lot of expectation from the menopause consultant for giving them a good quality of life. What is your QOL? So quality of life issues is very important, and it is our duty as menopause consultant to give them a quality of life. And that is why drugs are not only drugs, exercise, counseling, lifestyle modification, finally drugs. And the drugs which you offer should be safe, should the phobia of cancer should not be there, and that is why we are an alternative option in form of this drug estrogen 100. You can try. I am not promoting any product now. You are the best judge, and today is the day of evidence-based medicine. If you get a good drug, you should try it. If it is effective for your patient, you can go ahead, jolly well prescribe it. Otherwise, it will go to Bay of Bengal, because if it is not effective, if it is not potent, whatever claim they may have, it will be all useless. So please try this, and let's see how our elderly women are cured from menopausal problems. With these words, I thank you very much for giving me a patient hearing, and I am here to give any problem, any answer to your question, whatever you say.
Thank you, sir. Thank you very much for your excellent and very detailed talk. It is always an honor and learning to hear you, sir. And sir, if you allow me, then we will have a short Q&A session.
Yes, we can have.
Yes,
Sure.
sir.
How many participants, and is there any question? I'll be happy to take.
Yes, sir. There are actually appreciation messages from all the participants. Excellent presentation, very informative. and very informative presentation. Yeah.
Thank you very much,
And we have
Dr.
only,
Somer, sir.
yes, sir. And
Yes,
we have only one question, whether genitourinary syndrome of menopause is underdiagnosed or undertreated.
both.
Yes, sir.
In fact, I will like to say that genitourinary problems of menopause are underreported, undertreated, and they have a low expectation. Because most of the women who leak urine or having urinary incontinence, or they have genitourinary problem in form of dryness, dysphoria, loss of libido, they do not speak. Our women do not speak. They hide it. So they are stinking, they are smelling, but they do not know. But again, they do not know that there is a treatment is available. And they have a very little expectation from the treatment if at all they get. So it is both underreported and under treated. That is why the women do not get a very good quality of life. So we must tell our doctors, because the doctors must first know that there is a treatment available for urogenital symptoms. Urinary symptoms, genital symptoms. Urinary symptom mainly in form of incontinence, mainly or overactive bladder. So that there is a drug is available, they have a exercise, they have a non-pharmacological treatment is available, that we must tell our doctor friends. Second thing, there is a drug for incontinence is available, which they can take. For stress incontinence, there is a surgery available in form of TOT or TBT, that they must know, so that they will be able to pass on this message to our elderly women. Second thing, genital problem in form of dryness, dyspareunia, loss of libido. They must explain that this is because of hormonal depletion. And if you replenish with hormone, particularly local hormone, the vagina becomes again thick, it becomes moist, it becomes warm, the glands reappear, the secretion will be more, and there will be less difficulty because the lubrication will increase. And they should be encouraged to have more frequent intercourse, so that the concept of use it or lose it will not be there. But as because our women are shy, when some elderly patient comes to us for any treatment, any form of problem, you can ask them a leading problem. Do you have a sexual problem or urinary problem or a genital problem? Then with confidence, they will open up, they will treat. So that is why it is underreported, and that is why it is told that it is undertreated. Thank you.
Thank you, sir. And there is a comment from Dr. Krishna Kavita Ramavat saying that
Right.
thank you for organizing a very informative session, very well presented, a great learning experience.
I think the thanks should go to Shield Healthcare rather than me.
No, sir, it's a very
I am always there for any program of teaching and training. So I am not here to promote any product. I am here to teach science. And if we have a new molecule, if we have a new drug, the people must know, they must try, they must use it. They should get the first-hand experience from their patient that yes, this drug works. If it is working, most welcome. People should get a new molecule, people should use, and people should get the benefit of this new drug, and they must have a good quality of life. So that is my essence, that is my message to all my fellow gynecologists, all my fellow doctors who are listening to me today. So that extensively I told about menopause and menopausal problem, and the treatment options are available, the fear of women about cancer, the alternative therapy which is projected today, the alternative therapy which is how it has failed, and why a new drug has come, and how this new drug is working, and if it is working, if it is really working for them, they should use it, they should get, their patients should get the benefit out of it, so that everybody is happy. And the women, the essence of today's presentation is menopause and quality of life. The women will have a better quality of life, and I will be feeling satisfied if this message goes to our patient and who are the end recipient of this. Yes, Dr. Someshwar.
yes, sir. Sir, I don't find any additional questions in the comment box. So if you allow me, then we will close this webinar.
Yes, I am very happy. So
Dr. Haraprasad Patnaik, I'm Satish Kumar.
Yes, I know, sir. Dr. PC Mahapatra has told about he is my guru,
Yeah,
and
yeah.
he has
Thank you
told
so
a
much,
lot
sir.
about you.
Yeah,
And you have a
honored.
very frequent interaction. I have discussed a lot of issues with Mr. Balaji.
Yeah,
But
yeah.
I had the opportunity of meeting you today on a virtual platform.
Yeah, yeah.
And Dr. Mahapatra, my guru, my Shah, tells a lot about you.
Thank you so
He has
much.
all praises for you. And I have heard about you from him.
Yeah.
Yes.
Thank you so much.
Thank you.
Whenever I'm
Thank
coming
you,
next
sir.
time, we'll meet you. Thanks a lot.
Thank you very
It was
much.
a
Thank you,
wonderful.
sir. Yes, sir. Prachi here again. Thank you, sir.
Thank
So
you.
probably one more telecon, one more webinar is due regarding the genitourinary symptoms and
Yes, of course we can have it. Sure. I'll be there. Anything
Thank you, sir.
related to teaching and training and science,
Thank
I'll
you,
be
sir.
there always.
Thank you
Because
very much for your
my teacher, my guru, Dr. Mahapatra, always said that we should always go for a teaching and training program. Thank you
Yes.
very much.
Thank you, sir.
To everybody, all my listeners today, all the delegates today, with these words, we can leave and we will go to Jhansi, another program of sealed healthcare in
Yes, sir.
Jhansi. Thank you very much.
Thank you so much. Thank you. Nice.
Thank you. Namaskar.
Yeah.
Thank you, sir. Thank you once again, sir. And many thanks from the Shield team for all the participants.
Thank you.
Yeah,
Thank you,
thank you,
Sil,
sir.
Yeah,
very
thank
much.
you.
Thank you.
Hello, Satish.
Yeah, madam.
अच्छा हुआ program?
बहुत बढ़िया था, madam. I was there actually connected to that our YouTube Shield Connect.